Okay. So, yeah, like I was saying, there's a lot of connection between HIV, AIDS, and cancer, and just kind of public health and prevention and how we can keep patients safe. Just like we've talked about, like in MedSurg 2, and other classes, if we can prevent a disease from occurring or a condition from happening in patients, we're going to keep them so much more healthy than if we are treating an active disease or an active issue. So let's hop in first to cancer, and then we'll move into HIV later. I know, I feel like everybody's on the struggle bus today. Today just feels like it feels a little bit harder. And sometimes we just have to acknowledge that, right? That today is a hard, it might be maybe today's okay for you, tomorrow might be a hard one for you. It just happens. Okay, so let's move through. So we're going to talk a little bit about this cancer pathophysiology. I'm not going to go too in depth on like how it all happens, but want you guys to know that there's a mutation that occurs in our cells. There's a few things with cancer cells that are different than regular cells. It's a kind of important to know because it affects how cancer works. So they have this abnormal cell growth. They just grow and grow more than normal cells will. In fact, they don't have a division limit. Normal cells, anybody remember from the reading how many times normal cells will divide before they die? I think it's around 20, but don't quote me on that. It's a 2-digit number. It's pretty small. Cancer cells will just keep dividing and going. And so normally, like our regular cells, if there's something going on with them that's maybe not quite right, those cells are going to die. And then hopefully the healthy cells are going to be the ones that keep living. Cancer cells will just keep dividing, keeping those same mutations going. And they have this lack of contact inhibition. So meaning, hey, you get to be my person because you're right here in front of me. Normally, if we go to a coffee stand or Starbucks and we get in line, I'm going to come right here because you're in front of me. So I'm going to stop. Cancer cells don't have that same inhibition. They're like, oh, you're in line? Too bad. And I'm going to just keep pushing back and moving on beyond. So meaning your cancer cells are where normal cells in your body are going to grow. And if they run into something, they're going to stop growing. That's a growth inhibition or contact inhibition. Cancer cells don't have that. They're like, oh, I'm into something. All right, I'll grow into that too. They lack that kind of a social nicety to stop when they really should. Where do we get cancer? How do people get cancer? So a few different things. Carcinogen exposure. What's a really common carcinogen that we see people exposed to? Smoking. Yeah, smoking. That's probably one of the biggest ones that we have in the States. But it can be other things, right? Like chemicals or other pollution. If you work in a lab with things, that could be a way you're getting exposed. So risk factors, oncoviruses. Let's do some word building. What does onco kind of mean? Oncology or cancer. And then we know what viruses are. So those are viruses that we know tend to lead towards cancer. Anybody think of a kind of one that we hear a lot of, or it's kind of more common to hear about now? HPV, yeah, because we have this HPV vaccine that's relatively new in the world of vaccines. And the reason why they developed it, because it's not that HPV, the virus, is so bad for you. There's some negative effects from the virus, but they know there's a strong correlation between people who have HPV, an active virus, and then they develop different types of cancer. So we know that we need to, or if we can prevent that virus from occurring, then we can prevent it from happening. Can you see the number? Radiation. So radiation, yeah, if you work in like a radiology department, somewhere like that, you're getting maybe exposed to some radiation. But think about the sun, all this beautiful sunshine that's coming in. That's radiation as well, right? So when we talk about skin cancer, we're trying to protect from some of that radiation from the sun. Genetics. Can't get away from your DNA. Sometimes you just have familial things that get passed down. You're more likely to get certain types of cancer. But you guys are going to get into it a little bit more later. Diet plays a big role. You can have a lot of preventative factors with a healthy diet, and then you can have a lot of risk factors for cancer with an unhealthy diet. Your immune system plays a role in it, right? Because if you have an immune system that's disordered, I got you. Um, it's time to be recycled, poor bottle. It's trying to leave. So normally our immune system will identify these cells that are abnormal and it will get rid of them, right? Sometimes they aren't able to identify these cells like cancer cells, and they're able to grow. So if you have an immune system that's not working as well, not going to be as able to identify those cells and take care of them and kind of get rid of them like Jade just got rid of her bottle. Age also, right? As we age, we are more prone to our systems just don't work as well. Our cellular replication probably isn't going to work as well. As you get older, you're more at risk of developing cancer. This is kind of a nice picture. It's way too busy to talk about all of it right now, but it's in your book. I recommend taking a peek at it if you haven't already. It gives you a nice breakdown between estimated new cases of male and female cancers, as well as estimated deaths from those cancers. And it also kind of puts them in order a little bit. I think it orders them. Yeah, from highest likelihood to lowest likelihood. So I think this next one, oh, it's over here. We'll get to that in a minute. So types of cancer. It's important that we understand benign versus cancerous, because when we have a tumor, it's just an abnormal cell growth. Doesn't mean that it's always cancerous, right? Because a benign tumor, it actually usually will respect the line, right? A lot of times those benign tumors, they're not growing into other structures. They're playing by the rules a little bit more. So carcinoma, that's cancerous. And that's usually when we have skin, digestive tissue, some of our glands, respiratory. So if you have lung cancer, it's probably a type of carcinoma. A sarcoma, let's see, I don't know if I can move this so you guys can see it. A sarcoma is also cancerous. It's the connective tissue. It's usually bone or muscle. So if you have somebody that has a type of bone cancer, it's usually a sarcoma. The leukemia, right? Cancerous, right? Of your blood, right? Your blood. And then lymphoma, right? That also kind of makes sense. Cancerous, it's cancer of your lymph system. You also have, melanoma, that's skin cancer as well. I always remember that because melanin is produced in your skin. And so melanoma, that's the cancer of your skin usually. But then we also have lipomas, right? A lipoma, it's an abnormal growth in your fatty tissue, but it's not cancerous, it's benign. So if you have an abnormal growth, like maybe you're feeling like in your breast tissue, a lot of times it can be a lipoma or something that's not cancerous. Always need to evaluate those things, but a lump doesn't always mean cancer. Same thing, we have a fibroma. And so you can have fibromas in your connective tissue as well. And those are benign. Those are not cancerous. This is kind of a nice picture of a type of skin cancer. And some of the things you want to make sure you note, because a lot of patients, that's a big part of screening for cancer with patients, is making sure they know what to look for. So what are some things, like the characteristics of this that might point towards cancer?
It's like the
color, uneven texture. Yeah, it's not symmetrical. The borders are also uneven, right? Normally, normal growth, because sometimes you might have a mole, a wart, discoloration on your skin that you've had from birth. But the big thing too is if it changes. We can't see if it's changed. That looks gnarly to me. I would be very concerned if I saw that on a patient. But we also want to ask, like, how long have you had this? Has it changed in the last, few months or since you noticed it? Because change, as well as all the discolorations, irregularity in color, topography, outline, those are all very concerning. Metastasis. Metastasis is when you have a primary cancer source that is traveled. So meaning there's a lot of cancers that have common areas that they'll metastasize to. I think is it lung and bone? I can't remember. I should have looked this up. I see nodding, so maybe I'm right. But a lot of times they know if you have lung cancer, we're really gonna watch your bones because we know there's it's common for it to metastasize to your bones. I might be misspeaking, but just know a lot of cancers, they'll know, hey, these cancers like to travel. Like you guys probably like to go somewhere for vacation, right? You have your spots you like to go. Certain cancers have their spots in our bodies where they like to travel to as well. They go there and they lodge in and then they start to grow. Okay, so most common cancers. This is kind of what I was referring to when I was looking at that picture that had the men and women. Men, most common, prostate, lung, and colon. Women, breast, lung, and colon. Now, this is just general in the United States. It's really important to know wherever you practice, you might end up working here for the rest of your life. You might move to somewhere else. It's important to know what are the most common cancers in your area. Most likely, there'll be these three, but depending on where you're at and certain environmental factors, there might be some other cancers that are more pronounced. And you want to make sure you kind of know a little bit about them because you're probably going to see them more. I think it's kind of interesting that we both have lung. Hey, lung and colon, right? Those are two big ones for both man and female. And then breast and prostate, right? They're both hormone related. They're both have to do with your sex organs. So very interesting. Oh, I gotta click back in. Here we go. So prevention, right? That's the key for cancer. We're going to talk a little bit about how to, you're all good, or a little bit about how to take care of patients with cancer, but really our focus is going to be on prevention because if we can prevent this, man, we're going to be helping people so much, even just not dealing with the trauma and the burden on our health system. So early detection is really important. What are some of the screenings that we recommend for people for early detection? Breast exams, mammograms, pap smears, prostate exams, colonoscopies. Yeah. And so we have recommendations, usually comes from the CDC as far as when you should start. I think for women, mammograms are usually recommended at 40. I have a really high incidence of breast cancer in my family. I've done the BRCA testing and it's negative, but so have people in my family who've had cancer and they were negative as well. So there's just some genetic thing that they're like, we think that you guys have some genetic component that we haven't identified yet. So I started getting mammograms when I was 30. So it might be for general populations, we have certain screening thresholds, but people at high risk, we might have them have lower thresholds, meaning like somebody who has a high risk of colon cancer, we might have them start doing colonoscopies much younger than they normally would. We also, like I said, with genetic testing, right? If you have family with breast cancer and they have the positive BRCA gene, you might want to say, yeah, let's maybe get other people tested for this. And there's other genetic things, other cancers you can test for with genetics. Healthy lifestyle. What are some of the healthy lifestyles or components of healthy lifestyle? Exercise, diet. What about your diet?
Fiber, low sugar.
Yeah, low sugar, low processed food, more fiber, higher protein. If you look at the average person in the States, their diet has so much processed foods. And there's lots of links to negative effects of those processed foods. There are some protectant foods, folate, and then eating a diet high in fruits and vegetables. Those have shown to help protect people from developing cancer. And then vaccines, like I said, like we know the HPV vaccine, we know that's something that's going to help prevent different types of cancer. So we want to promote that. Change or caution. Sorry, and I realized I thought I had this in the weekly resource page and I didn't update the PowerPoints and the visual aids. So they're updated now. Sorry that I didn't have them before class. But there's a little visual of this as well. So caution is something that we use, and it's good to teach patients as well, to say, like we did be fast last week for stroke, right? So let's try to remember really quick, what is for be fast, what does the B stand for? Balance. And E, eyes, can they see? F, face, is it symmetrical, is it drooping? A, arms, right? What do we have to do with our arms? Yeah, hold them out, right? Hold them out. Is there drift? S, speech, how do they sound? And then T, time. Good job. And then for time, if you have somebody that we know when their symptoms started, what's the time limit before they are excluded from having TPA? 4.5. 4.5 is the limit of how long it can go. So this is another one. It's not as common as like be fast, but it's a really good tool to teach our patients how to screen for cancer. So change in bowel and bladder habits. What kind of cancer is that maybe referring to? Colon, maybe prostate. Oh, those are big cancers, right? A sore throat that doesn't heal, unusual bleeding or discharge, thickening or lump, indigestion, difficulty swallowing, obvious change to warts or moles, or nagging cough or hoarseness. You can see a lot of these, they're like, oh, colon cancer, maybe lung cancer, throat cancer. A lot of these kind of are going more towards the really common cancers that we see in the States. So how do you diagnose cancer? Well, it says biopsy on the top of the list, but you don't jump right to a biopsy, right? Somebody comes in with a nagging cough, they've been a smoker for 30 years. What are they probably going to do first? Right? Usually they do chest x-ray. Oh man, they maybe see something. After that, maybe they'll do a CT scan. They want to get a little bit more of a definitive view. From that, that's when they usually would order a biopsy. So biopsy really is the definitive way of actually taking cells out and testing them, looking to see what kind of cells they are. But that's kind of, you don't go right from a cough to go straight to biopsy. You might have MRI, ultrasound, endoscopy, right? Like you might have colonoscopy if they need to go in, if it's bowel, to check to see if there's cancer there. And then staging. So with staging, we look at a few things. One of those days. All right, so MO. What does it stand for metastasis? And it's no metastasis, right? M0. You don't have to answer, the question's already given, the answer is given. I pulled this box from your book, and because I thought it was really helpful, because this is when it's staging, T stands for that primary tumor, and you either can't evaluate it or you kind of look to see the size and extent of that tumor. N stands for lymph nodes. Has it gotten to the lymph nodes? Why is that concerning? It can metastasize, right? Because the lymph system, just like our circulatory system flows through our body, that cancer can jump in that lymph system and ride that highway all through our body to go metastasize somewhere else. And then distant metastasis, right? If it's kind of gone somewhere really close versus somewhere far away, that lets them know kind of what's the extent of it. There's also staging. Do they talk about that as well? I don't know if we have that in here, but staging has to do with some of the growth as well. Like stage 3 is that it's like the cancer has grown into other structures, maybe around the site, where stage 4 is like it's gone and metastasized to other spots as well. So you'll see a few ways of how we classify different tumors and cancers. So how to treat it? Typically people get maybe surgery. If they can go in, if you have colon cancer, they might have to go in, and if it's localized right there, they might be able to remove part of your colon. Some people I've seen where they've had part of their colon removed and they have a colostomy bag. And then after everything's healed, they're doing better. They'll have what's called a colostomy takedown procedure, and they surgically go back and reattach the bowel so the patient can go to the, have bowel movements normally again. Sometimes even with surgery, like with breast cancer, they might have surgery, a mastectomy, to remove the cancer. but then they still would do chemo and radiation as well. Because even though we think we maybe have all the cancer, we've removed it, we don't know for sure. And it just takes one cell to continue to replicate and cause more problems. So side effects, when we look at radiation and chemotherapy, a lot of their side effects are very common, or they overlap with chemo and radiation side effects. Fatigue, nausea, vomiting, anorexia, right? Not eating. What's mucositis?
Inflammation of the.
Inflammation, yeah, inflammation of your mucous membranes. We usually think about mouth, but remember, your whole GI tract is one long mucous membrane. So you can have irritation all through your gut, all through your bowel. It can be very uncomfortable. And then xerostoma, stomia, dry mouth. They can have really dry mouth. So a lot of times, some of our interventions might be providing like little water to slip on, some lozenges to suck on, some things to kind of help them with their dry mouth. And bone marrow depression, right? Because both the radiation and chemotherapy, they're targeting those fast growing cells like cancer cells. But the other cells in our body that grow fast are going to be affected as well, right? In our bone marrow, that's a fast growing cell. What are some other fast growing cells that might be affected by, like, especially chemo? What about our hair? That's why people lose their hair on chemo. It's targeting those fast growing cells. And so, I mean, fast, but that's part of the reason why you can lose your hair. Oh dear. Okay. When we're maintaining a safe work environment with patients with radioactive implants, what are the key principles? And it is time, distance, and shielding. I'll make sure for the next Mentee, I actually get your questions. I used to work on a unit where we did the ionized thyroid, or iodine for patients with hyperthyroidism, because they were just hyperthyroid all the time. And so we were actually trying to shut down that thyroid. And so that radiation essentially, because their thyroid's going to take up that iodine and it would kind of kill the thyroid, which is kind of what we wanted to. Then those patients have hypothyroidism, but that's much easier to treat, right, with like levothyroxine or something. Than the hyperthyroidism was. Yeah. Always complications with everything. You can, just like with any radiation, all those side effects that you might have. But usually it's short-term and localized. So when we would have these patients that would come in, typically they would stay a few days in the hospital. And I always felt really bad for them because they were in a room by themselves. We would keep the door shut. We would really try to minimize contact with them, right? Because as healthcare providers, we don't want to expose ourselves as much to that radiation. But you learn some tricks too, because distance, right? Distance is a factor. So instead of maybe standing right here and talking to the patient, I try to take a few steps back, and I also tell the patient too, hey, I'm sorry that I have to stand a little bit back from you. I want to hear what your concerns are, but you want to kind of give some distance too. There's also shielding. So if you're working in an area that has a lot of radiation, like interventional radiology or in radiology or sometimes surgery, if you're in surgery and they're using a lot of x-ray or fluoroscopies, you'll see they have those aprons and then the vests and then like this little thyroid shield you have to wear around. They're trying to protect your body from the areas that tend to take up the radiation. I think there's something else I was going to say, but I can't remember. So chemotherapy, a lot of times they'll do a combination, maybe not just one type of chemotherapy. They'll combine a couple different types of chemotherapy. Okay, so cue recognition. You enter the treatment room and Mr. X complains of burning in his IV, which has a vesicant anti-neoplastic running. The site is edematous and red. before we turn to our neighbor, anti-neoplastic. What do you think that means? It's for cancer, right? So it's anti, against, neo, and the anti-neoplastic means for like it's one of our cancer drugs. So turn to your neighbor. This is your patient. What would you do? All right, let's check our answers against F.A. Davis's answers. So stop the infusion. I heard a lot of that. Leave the IV in place. It's a little bit different because I think before, when you guys have talked about extravasations or maybe just infiltrations, it's like take it out. For these purposes, you want to make sure you go and notify the RN, notify the healthcare provider. These can do a lot of damage to the skin around. And so we want to make sure people who are trained in treating that, sometimes they'll go and they'll try to aspirate out any of the medication that's leaked or know exactly where to treat it. So you don't necessarily just take it out right away. You want to follow your facility protocol, right? So there's going to be different things that they do or give for that. So you want to make sure if you are in a place that gives chemotherapy, it might not be optional. Usually they make you take all the trainings to have those types of jobs, but always follow the protocol. And then document, right? Whenever I've had a patient that has some sort of infiltration or whatnot, I've got my marker out and I'm always do because I want to see if it's growing, if it's expanding beyond those borders. I want to kind of look at it. Vesicants can cause a lot of tissue damage. It might be lasting. It might not be just temporary. It could be a long-term damage that they have. And here is a picture. This was a patient, most likely that was a portacat that was giving chemotherapy that got dislodged from the port. And you can see how it just leaked out into the skin and it's caused that damage that's there. So that's not a bruise. That's actual, like probably tissue necrosis around the site from the medication. Yeah, from the chemo. Chemo is very toxic. Yeah. All right, so side effects of chemotherapy. These are probably going to look really similar to the side effects of radiation. Bone marrow suppression, nausea, vomiting, diarrhea, stomatitis, alopecia, right, with the hair loss. You might have some reproductive alterations, not meaning that people after chemo can't get pregnant or produce a child, but they might have some complications with that. And there can be neurotoxicity that happens as well. Oh, goodness. All right. Interventions for patient with thrombocytopenia. What is thrombocytopenia? Yeah, low platelets. Penia, I always think is like petite or little. Thrombocytopenia is your platelets are little. You don't have a lot. And so for these guys, we want to protect them from injury and report any bruising or bleeding. BITES is a good little acronym to help you remember side effects of the chemo and radiation. Bleeding from the thrombocytopenia. Infection, what is that from? Leukopenia, right? Decreased white blood cells, leukopenia. Tiredness, emesis, and they might have some skin changes. It could be from chemotherapy, but often with radiation, especially if it's external radiation. Oh, that's the thing I forgot to say. With what are the 3 things that will help protect you from radiation? Time, distance, and shielding, right? So sometimes the radiation is external, like, you're doing an x-ray, you're getting like fluoroscopy. Sometimes it's that patient with the iodine for the thyroid. There's also like patients might be sent home with like they have prostate cancer. They might have some little radiation beads put up there to help hopefully kill that cancer in the prostate. Really important we give education because we talk about time and distance. So let's say that patient with the prostate cancer has those radioactive beads. Should he sleep in the same bed as his wife? All right, because that's a lot of time, the whole length of night, and the distance, they're pretty close. So we want to give good education, even if they're not at the hospital, to their family members and the patients, so they know how to protect each other as well. Okay, cue recognition. Your patient received chemotherapy 9 days ago. She complains of severe shortness of breath and fatigue, and she looks pale. She can barely walk into the exam room. All right, so turn to your partners, and not only what do you do, but what do we think is going on with this patient? All right, let's check your answers with F.A. Davis. And they said, first of all, safety, right? Who did anybody say safety? Make sure she's safe to get where she needs to. Okay, good job. Because I think a lot of times we go right to, she's probably anemic, right? We probably need to get labs, we notify the doctor, but let's NCLEX prep tip for you right here, right? Safety is always going to be your priority. Make sure she can get to where she goes without passing out. Want to check her vital signs, including O2 sat, and then talk about what the normal data is, abnormal data with the provider. I can't get that out of the way. There you go. So hemoglobin and hematocrit, that's going to let us know if she's anemic. You might want to type in cross. And then Epotin. Anybody remember, what does Epotin do? Help stimulate red blood cells. What's another patient population we give this a lot in? Kidney. Yeah. Why do patients with kidney failure get Epotin?
I think it's because Epotin is secreted by kidneys, so it has to lower it.
It's not Epotin, but it's the erythropoietin.
Oh,
Erythropoietin is the hormone that the kidneys secrete that stimulate red blood cells to work. So we give it a lot in renal failure patients because if their kidneys don't work, they're not secreting that hormone. Epotin's an artificial hormone to help that. Cancer patients, if their bone marrow creation is suppressed, we often will give them some of this to help increase that bone marrow to produce more red blood cells. And she might need a transfusion, right? We might not be able to wait around for the bone marrow to be like producing extra. She might need some help right now. Oh, click back in. She may be experiencing anemia, and we know that our red blood cells carry oxygen. That's probably why she's short of breath, because if she's anemic, she's not getting enough oxygen in her system or to her lungs. Oop. Some of the nursing diagnoses we might see with our patients with cancer: ineffective coping, acute or chronic pain, risk for infection, ineffective protection, imbalanced nutrition, grieving, social isolation. I think especially our patients who are either like the radiation patient, or especially our chemotherapy patients who they're very leukopenic or they're very neutropenic, maybe, where they don't have their immune system is very depressed. And we know if they get an infection, that could vastly affect them, right? Because if they're sick, they're not healthy enough to get their chemo treatments. So they really want to be protective of themselves so they can continue getting the chemotherapy to treat that cancer. I have a good friend I was talking about yesterday who she was getting chemotherapy and she was just so lonely. And so one day I was like, let's just go get coffee. And I picked her up and we both wore masks. And this was before COVID. And we both wore masks, and I had the windows rolled down in the car so there'd be lots of airflow. And we just went through the Starbucks drive-through and went down to the water and just like looked at the water. And she was so, actually, it was beautiful. And because she was just so lonely, she was like, oh, like, because she just was lonely. She said her neighbors had puppies, and she would just look out the window because every once in a while she'd get a glimpse of the puppy. And like, that's what she was living for. Like that, they get so lonely, And so that's a big deal. I think now there's so much that we do virtually, that's available virtually. I think that really has helped our patients in the last decade or so. But if we have older patients who aren't technologically savvy, they might not know how to access that. And it's different being face to face with somebody. So just being aware. And then disturbed body image, right? I think especially our breast cancer patients who have had mastectomies, their whole body is looking different, it's feeling different. That's a lot to kind of take in. Or patients with colon cancer, yeah, they lose your hair, absolutely. Men and women, right? A lot of times we think about it's the women who suffer from losing their hair, but men too, when they lose their hair, that's altered. Yeah, great point. There can also be caregiver issues, right? Because the family hopefully is very involved. They might have some role strain, or there might be some knowledge deficit that we need to help correct. They can take care of the patients effectively. Survivorship, right? Cancer is not a death sentence. A lot of patients go on and live great lives, but having cancer, going through treatment can be a very traumatic experience. And so we want to make sure that even after the cancer has been treated, that we look at these people holistically and like, what do they need for their ongoing medical needs, their psychological needs, their emotional needs, because it can be a lot to recover from in that way as well. Okay, hospice, I'm just gonna go over here. So hospice care, it's usually for less than 6 months prognosis. I mean, you probably will pass, that patient will probably pass away within 6 months. Often 12 months locally, I've seen like that's kind of the standard as well. It can be inpatient or outpatient. There's an interdisciplinary team where it's not just, you now have a hospice doctor that works with you. You might have a hospice doctor, a nurse practitioner, a PA, but then you also have this big team that comes around you and just says, hey, how can we make you more comfortable and help you at this kind of end of your life? They also really support family and caregivers. Up to a year after the patient has passed away, they can provide support to the family. One thing our book didn't talk about is palliative care. And I think it's important that we know that palliative care is another option for these cancer patients. And I think it's very underutilized. And palliative care isn't the same as hospice. It's not like staging of diseases where you're in palliative care and then you progress to hospice. Sometimes that happens, but palliative care is really just saying, okay, you have a chronic disease that you're probably that's gonna be what you end up passing away from. I think about our patients with COPD, with chronic lung issues, usually after decades, they do end up passing away from respiratory complications. But it doesn't mean that they're gonna pass away right away. Palliative care comes in and they look at this patient and they want to look very holistically. And they also really look at quality of life and say, okay, what are you doing now? How are you feeling? What would you like to be doing? What would make you feel more fulfilled in this life? And it doesn't mean we want to make that, it's not a make-a-wish thing, right? It's not like, hey, let's make this happen this year. It's like, how do we make your life as best as we can? They also help, I mean, they might consult in if you're progressing, they might consult in hospice care if it looks like that patient might be deteriorating a lot. But they also really can help with end of life decisions, right? Saying, hey, you've got this disease that, eventually it's probably going to be what happens with you. How do you want to pass away? Which is a very kind of scary question to bring up with patients, but it's a very helpful thing because a lot of times people don't want to talk about it, but a lot of times after somebody passes, we want to honor and respect their wishes, right? And if we don't know what those wishes are, especially if they want to be a DNR, if we don't talk about that, we don't know. So we just want to make sure we have those conversations. Stage 4 breast cancer patients, what lab may indicate further metastasis? Calcium. Okay, calcium, is this a high or low number? It's high, it's hypercalcemia. There's some cancers that we see really affect some of our calcium levels. So with breast cancer especially, we want to make sure we're looking at their calcium levels because it can really affect that calcium and drive it up. Oncological emergencies. Your book had teeny little paragraphs for all of these. So we're just gonna go over it really briefly. Superior vena cava syndrome. Where's your superior vena cava? Yeah, up here. So superior above, you also have an inferior vena cava below. And where does the vena cava lead into? Yeah, right atrium, right? It's a vena, it's a vein, so it's returning blood back to the heart. If you have something, a tumor, whatnot, that's blocking that superior vena cava, you're gonna have issues with, depending on where it's blocking, of like that blood flow being backed up, causing problems. Might see JVD, some other issues. Spinal cord compression, right? If you have a tumor that's starting to push in on your spinal cord, what kind of symptoms might you see? Paralysis, maybe not right away, but eventually, right? Usually, so if you think about, let's go back to some of the diseases we talked about last week where we have some nerve involvement. What do we usually see first? Pain, weakness, numbness, something where we can tell that something's being blocked. If we can't stop the progression of that tumor, then yeah, it would cause probably paralysis eventually. So we want to make sure we're looking at that. Hypercalcemia. Hey, we just talked about that. And then tumor lysis syndrome. This is where if somebody is getting chemotherapy, radiation, but usually chemotherapy, within like the day or a couple days after treatment, those cancer cells should be getting destroyed, right? They're lysing. But they're releasing all kinds of toxins into your system. And so you might see patients get acutely ill right after they had that chemotherapy treatment. And it's from the toxins from the cancer being destroyed. So we want to make sure if we see somebody who's getting acutely sick after chemo, we want to kind of look at them to see, is it their white blood cells getting destroyed and now they have an infection? Or is it maybe this tumor lysis syndrome and we need to help support them through that? And okay, that is it. Do you guys want to do a short break or go into the case study and do a little longer break? Short break? Okay, let's get up and move. So let's just go until 9 o'clock and then we'll take a little bit of a longer break a little bit later. Okay, so we're gonna get into talking about HIV and AIDS now. You guys did a great job on that group work. Nice job. So once you have joined the Menti, either with the QR or with the code, go ahead and give me a reaction, thumbs up, heart cap, thumbs down. So talking about HIV and AIDS today, I remember when I was a nursing student back late 90s and early 2000s, and we had a clinical rotation that was going to take care of patients with not cancer. I mean, they probably had cancer, but with AIDS. And I remember so many of my colleagues, my peers in nursing school were terrified. They're like, oh my gosh, are you gonna like, do you have that rotation? Like, what are you gonna do? Like, you gonna touch them? Like, what about if you get AIDS? And there was so much, even then, that we didn't quite understand as a society, but also, we were students. We didn't know all the things. I'm so thankful that our treatments for HIV have come so far. Our public awareness and preventative strategies have really come a long way. It used to be kind of like cancer used to be a death sentence a long time ago. If you had cancer, you were sorry, there weren't a lot of treatments. HIV, I feel like was kind of a similar thing once you were diagnosed, especially if you were had AIDS, there weren't a lot of options for you. And so I really am so thankful that in our country and in our world, there's a lot more, there's been a lot of work actually. I don't want to say it just has happened because it really has been on healthcare providers that we have strived to make a change in this disease. So I'm really thankful for this. All right, so getting in, hopefully you're here in the Menti. If you're not, I have the code on the board. So first question for you, the nurse would recognize the need for further teaching. Okay, so test taking strategy, need for further teaching. What does that tell us about the question? What are we looking for in the answers? Right? The answers are going to be wrong, the wrong information. So further teaching about HIV if the patient stated which of the following, and is select all that apply. All right, and correct, HIV is an acute infection, right? It's not an acute infection. What kind of infection is it? Chronic, right? It can be progressive, and we know that's true, right? It can be over time, HIV can cause AIDS. It's kind of the last stage of HIV. HIV is curable. Oh no, we can get it to where it's undetectable, but technically they are not cured from the disease. And ART increases HIV replication. ART is antiretroviral therapy. It's a hard one. So we're just going to say ART. And we know that it doesn't increase the replication. It actually helps decrease it. All right, so moving in, HIV is a chronic infection when it's treated. But sometimes if it's not treated, actually not sometimes, if it's not treated, then it becomes progressive and the patient will develop AIDS over time. Well, I don't know why I said that so weird. Okay. If you are infected with HIV, not exposed, infected, we'll talk about how you can become infected. There's kind of two paths. If you are treated with the ART antiretroviral drugs, then oftentimes you can go into kind of like a remission where your symptoms are controlled and you won't necessarily develop HIV. If you contact HIV and you are not treated, we know that you will progress and develop AIDS. So there's kind of two paths that patients can go on. So untreated, you will develop AIDS over time. So age is the final stage of the HIV infection. We do not have a cure for it, and it can be fatal. From 2018, from the United States, 1.2 are infected with HIV. 14% were in 2018 still unaware of their infection status. There were almost 40,000 new infections with HIV. 42% were Black individuals and 19% were women. So we can really see kind of, especially with 42% of our Black individuals, that's a big disparity that we want to address. Hopefully that was 2018. I'm hoping that all those numbers are kind of decreased and we've minimized HIV in our community in the States. There are two subtypes of HIV in the United States and worldwide. Mostly you have HIV-1. It's when people talk about HIV, they're typically talking about HIV-1. It's more pathogenic, meaning that it's more likely to cause the symptoms and the disease progression that we think of when we talk about HIV. There's an HIV-2, primarily found in West Africa. It's less pathogenic, not meaning that it won't cause any problems, but you don't see the same symptoms, the same severity as you see in HIV-1. You can be infected with both, unfortunately, right? Because if you're exposed to one virus, doesn't mean you're not going to then, or if you contract one virus, doesn't mean you're not going to get another virus as well. So they're not exclusive. But I should say, you're only usually going to find HIV-2 in West Africa. So think about if you travel or you're exposed to somebody who's come from West Africa recently. Yeah. I think the treatment, usually with HIV-2, it's much less severe. So the treatment for HIV-1 is going to be, it should be able to cover what HIV-2 is. The needs of HIV-2, honestly, I'm not too familiar with treatment for HIV-2. Okay. I'm not going to go into all the stages of HIV specifically, but what I am going to do is just kind of go through, because what I want you to understand is that there's different drugs, medications that affect the different stages of the HIV progression. So at the binding stage, we have these agonists or antagonists that block the HIV from just attaching, first of all. Then there's these fusion inhibitors, right? That's the next step. They're like, no, that's not going to happen. We also have non-nucleoside reverse transcriptase inhibitors. Oh my gosh, hard to say, but they're at the next step when there's this reverse transcriptase. Your book has this whole, I think like with the picture and everything about how the cycle works. It's another medicine that's like, no, I'm going to stop this part of the cycle as well. Integrase, we have integrase inhibitors. When HIV goes to replicate, we also have these other replication inhibitors. We don't really have medications that I know of that affect the packaging, but we do have the budding stage where we have the protease inhibitors. I'm not going to test you on all of these ones, like what medicines are attached to which stage, but I think it's really beneficial to understand that we have all of these different medications that they affect different stages of this, of the HIV process. Because when patients are put on medications for HIV, they usually are given 2 or 3 different classes, different types of medicine, because we don't want to put like all our eggs in one basket, right? We want to say, hey, I'm not going to do everything right here at the budding process. No, I'm going to do something here, something here. I'm going to add this in too, because in case something gets through, I want to make sure that, you know, we're covered. Okay, the initial infection, CD4 counts are typically going to be what people look at with HIV. They're going to look at your CD4 count. Normal is about 330, I believe. I think, okay, good, it's here. So they have this picture of like your CD4 counts. And when you're first infected, you have a little dip in your CD4 counts, not a lot, but then you just have this kind of latent period where you are infected or the patient is infected with this disease, but they don't really have any signs and symptoms because their CD4 count's maintaining. It can be, I think, what did it say, 10 to 14 years before you start having symptoms, 8 to 12 years. That's in the ballpark. And so you can be living a very long time and not know that you've been infected with HIV. That's why it can be so rampant and in its transmission, because people don't know they're infected and can infect others. You start having, after that, about a decade or so of life, the HIV virus does impact your immune system so that your CD4 counts start to drop. Your immune system is kind of getting more suppressed. And that's when you start having these symptoms of HIV, as your immune system is finally not able to overcome this virus. Eventually, if you're not treated, that CD4 count, your immune system is going to be so suppressed that you're not able to combat any infection that hits you is probably going to overtake you. And usually people from AIDS will pass away from some sort of infection. So you get diagnosed with AIDS, usually your CD4 count is less than 200. I'm not going to get into the percentage of things. And you also might see patients have these opportunistic infections, meaning normally we're walking around in crowds, we're in a group right now. It's very possible that any number of us have little viruses in our system that our body is fighting off. We might not even know about it because we have working immune systems and we're fine. But somebody whose immune system is not working, that virus could be spreaded. Like if it's a respiratory virus, right? We might cough a little bit and that gets transmitted to somebody who doesn't have a working immune system. Well, they're probably going to be affected by it, right? So these people that have AIDS aren't going to have a really great working immune system. So they're going to have lots of infections that start popping up. One thing we want to make sure that people know that if you're infected with HIV, you're HIV positive. You don't have AIDS, right? If you're not treated, it could progress to AIDS, but being HIV positive does not mean that you have AIDS. I think there's a lot of social stigma that can have with HIV and AIDS, and we're going to get a little bit more about transmission and things, but I think it's so important that we help people understand what that, like HIV does not mean AIDS. Excuse me. So prevention, just like we talked about with cancer, prevention is so key to help the spread of this disease. The CDC recommends that all ages older school age and up through adults should be educated about HIV transmission. There's a plan, healthy, what is it? The 2030 Healthy People, I think is what it is. It's our federal government has goals about like how to be more healthy. Like Michelle Obama, when Obama was in the presidency, she had one of her healthy goals was to reduce childhood obesity, right? There's different goals that we have to try to help. So one of our goals is to reduce new HIV infections by 90% by 2030. So I'm glad, those are good goals. The rest of the goal, we want to increase the knowledge of HIV status, get linkage to medical care, get people connected, because if you lose medical care, you lose your access to medical, like pharmacy benefits, things like that. You know, those patients, they're not on that treatment path anymore. They're not able to get those medications. They're going to move more, getting closer towards developing AIDS. We also want to reduce perinatal transmission. So one thing, there's a study in 2016 that showed that older adults have higher rates of HIV. I think it could be multifaceted. I think that there was a much larger spread of HIV in the States, you know, decades ago. We weren't as aware, we didn't have the same education, we didn't have the same testing. So I think as those people who had HIV are aging, we're going to see an aging HIV population. But we also have people who, when they're older, we know that if they're 50 and older, they tend to be less likely to get tested for HIV, and they're less likely to use safe sex practices like condoms. So they're more at risk of contracting it as well because of some of those habits. Older women are even more at risk, and HIV and AIDS, there's some neuro issues that can happen, some neuro deficits, kind of can mimic some dementia, other things. And so if we don't think about maybe testing them for HIV and AIDS, we might miss that this isn't an early dementia. This is actually a sexually or otherwise transmitted disease. Okay, so if the nurse is assisting with educating at a health fair, which of these would the nurse include as modes of transmission for HIV? Select all that apply. Excuse me, guys. Okay, let's check. All right, so men who have sex with men, right? It's actually heterosexual contact as well. Anybody having sex with anybody is a potential transmission of disease. I think especially in the like 1980s, that was a big kind of miseducation of like, oh, it's only in homosexual men, right? It's only for men who have sex with men. We know that's not true, right? It's transmitted in other ways than just sexually. Injection drug use, right? You're sharing dirty needles, dirty supplies. You can contract the HIV virus that way. You can't have it by handshaking or giving a hug. It's not that light physical contact. It's very intentional. Yeah. It'd be, well, I think it depends on what you're doing when you're kissing. If it's like a little peck, you're probably very low risk. If there's a lot of open mouth kissing, if there's saliva being transferred, if you have cuts or anything, so, but yeah, I think you're okay. And then sharing dishes and eating utensils, that won't transmit HIV, right? It's just like anybody pulling a clean dish out of the cupboard, that's fine. You know, you maybe don't want to like share forks like as you're eating, but it's just having like being in the same kitchen, using the same supplies. That's not going to increase your risk of HIV transmission. But let's talk about this. What do we include as sources of exposure of HIV? Excuse me. All right. Nice job. Blood, semen, vaginal secretions, and breast milk all can transmit the HIV virus. Tears cannot. So it's a fragile virus. So when I said it kind of has to be intentional, like there kind of has to be more intentionality. So like kissing, like unless you're kind of gnawing on somebody's tongue, you are probably at very low risk of getting HIV from kissing. Come on, Amanda. And the thing I want you guys just to remember is that HIV is not spread casually, right? It's usually from very direct, intimate contact of some sort. Even if that intimate contact is like sharing needles, right? That's a pretty intimate thing to do with somebody. There's no transmission by air, water, food, or insects. And when we donate blood, like if you go donate blood, they test that for HIV and AIDS. So there's really no risk of patients who are getting blood donated, like if they're getting blood, for them to contract HIV or AIDS through receiving a blood transfusion. Entered into the body sexually, talked about that, parentally, and then perinatal. So also like we don't think a lot about it, but babies, right? If the mother is HIV positive, then that baby can be exposed to either vaginal secretions as the birth is happening or through breast milk as well. Which of the following would the nurse include when teaching about PrEP? Ooh, this will test you to see if you remember what PrEP stands for. All right, so PrEP, that's the preventative prophylaxis. So we want to offer it to people who are highest at risk. It is an antiretroviral drug and a daily pill. It's not an injection, and we still want people to use other precautions. Just because you're on this precautionary medication doesn't mean you shouldn't use condoms, that you should be able to share needles. We want you to still be careful. It can be 99% effective for people at risk. It's usually Truvada or Descovy. Yeah. And like I said, make sure we emphasize the need for other precautions as well. HIV counseling and testing. We know the CDC has guidelines for it, but they really recommend testing once you're 15 years old to 65 years old, pregnant females, or after sexual assault. It's confidential, anonymous, and then we want to have post-test counseling by trained personnel. So you guys, after you graduate, are not going to have to walk in and start giving people post-test counseling if they're HIV positive, right? That's some training that you would have to do. Because they want to be able to explain the test results, make sure they understand, right? You were diagnosed with HIV, this is not AIDS. There's a path you can go on that will help keep that in check. You also want to talk about informing sexual partners, people you've shared needles with. You want to encourage those people to get tested, right? Because otherwise that disease is just going to continue to be spread. And then talk about care options, right? Let's see what is going to be the best treatment for them. HIV and sexual transmission. We want to make sure people understand that anal sex is the highest risk. I think a lot of times in schools, we talked about safe sex practices, and a lot of times we focus on there's STD prevention, but also like with pregnancy prevention. And so I think it's important that people understand that anal sex might prevent pregnancy from happening, but it's not going to prevent an STD like AIDS or, HIV from being transmitted. Women have a greater risk of contacting HIV through sexual transmission, and it's just because of their body surface, right? A lot more mucous membranes. If they can have that pre-exposure prophylaxis, the PrEP, there's a lot greater decrease in that transmission. And one thing that's really important to know is that if the patient has been contacted or contracted HIV, they have HIV, but they've been on medication treatment and they cannot detect any HIV in their blood for 6 months, they're considered untransmittable. It's not that they're considered cured, right? Because they need to continue taking that medication to keep the HIV from progressing. But they're saying, hey, once you've hit 6 months of not being able to detect, we don't think you can transmit this to anyone, which is very reassuring for people who have loved ones who want to, still have intimate relations. Safer sex practices. It's something as nurses we're probably going to be involved in some way or form. Abstinence is an option. We encourage people to be monogamous with their sexual relationships or limit their sexual partners. Use gloves, condoms, dental dams. We also want to talk about how like parental transmission, right, through IVs or IV drug use. Really want to make sure people know there's risks of sharing needles, of sharing drugs. There's some places, I know a while back in Seattle, I was reading about, they have a clinic you can go and you can get clean needles and clean supplies to use if you're an IV drug user so that you don't transmit different diseases in that way. There's also autologous blood transfusions. So if you're very concerned that you might contract HIV from a blood transfusion, even though it's very low risk, you can donate blood and then receive that blood yourself. I've seen this before, but usually I've seen it in patients who are Jehovah's Witness or they have other religious beliefs where they don't want to accept a blood donation. But some people will say, hey, I don't want to accept a blood donation, but I know this procedure I'm going to have is a high risk of needing blood. So several weeks beforehand, they'll go donate blood. That blood is stored and it's packaged and kept available. It's sent actually to the hospital or surgery center, wherever they're going to be at. And so if that patient needs a blood transfusion, they can just have their own blood. They want to make sure they do that a little while before surgery, right? You don't want to donate blood and then go have surgery the next day. You'll probably be a little anemic, a little dehydrated. So there's certain stipulations with that. Perinatal transmission. So one thing we really want to do is offer testing when we discover that they're pregnant, right? We want to make sure we know if they have HIV. If somebody is high risk, IV drug users, sex workers, we want to make sure that we are testing them again in the 3rd trimester, making sure we see if we can find if they have contracted it. And if somebody's not been tested at all, we usually try to test them when they come in for labor and delivery, like to actually give birth. If they're HIV positive, we recommend that antiretroviral therapy, not only during pregnancy, but during their labor and delivery process to hopefully decrease the risk of transmitting HIV to the baby. So prevention for healthcare providers. This is a big piece. Like I said, decades ago, when I was a baby nurse, there were people like, you'd be like giving report and you'd be like, oh, or, and then everybody was like, oh, okay. And like, it was really scary. But now, like the big piece I want you guys to come away with is use your universal precautions. Because if you glove anytime you're going to touch something that has blood, body fluids, whatever, if you expect there might be some splashing of some sort, get a face mask, do all the things that you should be doing. If you use the standard precautions, then it doesn't matter if your patient has HIV or AIDS or whatever. You're going to be protecting yourself from getting exposed. Needle sticks, right? Most healthcare providers, the biggest scares they get about HIV is usually through an accidental needle stick or a blood exposure. So you guys learned about recapping needles when you're in foundations, right? How do we recap a needle? A scoop, right? Hopefully only before that needle's touched the patient, right? Hopefully it's like a vaccine that you've had to draw up from the bottle. And then before you take it to your patient, you're not gonna be walking around with a free needle through the hallway. I mean, maybe, I don't know. Please don't though. But you're gonna scoop it up so you don't get poked. After you've given it to the patient, hopefully there's those safety devices that can cover it. If you don't have that, I encourage you, bring a sharps container with you, because if you don't have one in the room, right? Most places have sharps containers in the room. I've seen places, some of our long-term care facilities, they don't have sharps containers. But I'd hate to try to walk around with a hot needle that's already seen a patient to go find the sharps container. Shouldn't do that. I really don't want you to. So think ahead, if you're gonna go give an injection, bring a little sharps container with you. If you don't have it, cuss out your boss, right? Concerned, uncomfortable, safety, like, right, bring up those things because it is a safety issue if you don't have access to sharps containers how you should. Okay. What else we go into this? So the nurse experiences a needle stick. Which of these actions should the nurse take? Select all that apply. Wash it with soap and water. Actually, let me read it. All right, so yes, wash the site with soap and water. If you get stuck in your hand, wash it. If it's a splash or an exposure to your eyes, you're gonna flush it. One time I was removing an IV that had blood backed up into it. And when I pulled it out, I don't know what happened. It got caught on the tape and that bloody fluid went floop and it like got in my eye. It stunk because I had to go and take out my contacts and like sit in the wash thing for like 10 minutes. Have you guys seen the little wash things that come up? That's why they have them in case there's exposures to blood or fluids or to chemicals. And then I had to go to the ER because what you need to do is seek urgent medical care. If you are ever exposed, well, the first thing I want you to do is go treat it, right? Go flush your eyes, go wash off whatever you need to do with that. But then the next thing I want you guys to do is go to the emergency room. And if there's ever pushback from your charge nurse, from wherever, I meant to look this up last night. I think by law, they have to allow you to go seek treatment, like find someone to cover for you. Because you don't want to wait till the next shift gets here. That could be hours until you can go. So what I told people yesterday is just say very authoritatively, by law, I have to go seek treatment. I don't know that's true, but I think it is. So just say it with a lot of authority because you should, because we know that if you are exposed, especially if somebody has HIV or AIDS, we want you to begin that treatment within hours. We don't want you to waste those hours by finishing up taking care of your patients. Bum, bum, bum. Yeah, don't wait for a week. That'd be too long. Want you to follow your protocol. They also want you to consider the risk. So if you ever do get an exposure, maybe you have a needle stick from somebody has AIDS. That's a known source. You go to the ER and they're going to test you first of all. They're going to take your blood and they're going to see if you have HIV or AIDS first, because they want to make sure if you just get a needle stick, you're not going to show up as positive right away. You might not even contract it, but they want to make sure they know what your baseline is. Then, if the patient is known to have HIV or AIDS, they know that. If they don't know if the patient has HIV or AIDS, they're going to go test the patient. They're going to go send up lab work, test the patient. And then you're going to get counseling from a doctor or a nurse practitioner, some sort of provider, and they'll say, listen, based on this patient, you're at this kind of risk, right? If you are taking care of a patient who is homeless, uses IV drugs regularly, admits to sharing needles, and is a sex worker, that person is a really high risk of having HIV. And so they're probably going to recommend you start the antiretroviral treatments right away. If it comes back they're negative, you stop the treatments. You don't have to continue them. But we know there's a decreased risk of you contracting if you start right away. If, in my case, I went down and my little gal was this little old lady who was very low risk. And so I chose not to start the antiretroviral therapy before that. That was a risk though, right? Because even though if you have like some 90-year-old nun, we don't know her life. we don't know. Everybody has things that we don't see from the outside. So just know, you can choose to not start it if they're low risk. But it doesn't mean they will for sure not have it from being low risk. There are side effects of the antiretroviral drugs, right? You're suppressing your immune system. If the patient is unknown at all, meaning we don't know who the patient was, you were cleaning up a linen cart and somehow a needle got left in there and you got poked, you have no idea who that patient was. A lot of times for that, they'll recommend that you have the antiretroviral treatment for a while because there's no way of knowing who that source patient was, of being able to test them or even finding out if they're a high risk or low risk patient of having it. And if you complete the treatment 28 days, and the best case scenario is if you start that within hours of treatment, that's when you're going to have the lowest rate of contracting it. We talked about this a little bit already, but it's the stages. So if you're first contracted with HIV, you usually will have a little bit of a suppression of your immune system. Oftentimes, you know, these symptoms, it could just be a cold or a virus or somebody's like, I don't know, I'm coming down with something, but it usually resolves after a couple of weeks. And then people feel fine or normal for them for years. That stage 2 is that chronic infection, untreated 10 to 15 years. And then it's when that CD4 count finally drops, usually 200 or below, is that when they start having symptoms. Shortness of breath, weight loss, night sweats, persistent diarrhea, all of these things that can develop, a lot of it's from the immune system being suppressed. Sometimes if the CD4 count is above 200, but they have all of these opportunistic infections, they've already been diagnosed with HIV and they have all these issues of infection, the CDC might say, hey, you can go ahead and diagnose, like we're allowed to diagnose, we aren't. Providers can diagnose with them based on kind of some of their signs and symptoms that with the infections. Complications, there's a wasting syndrome, weight loss, more than 10% of their weight. Additionally, for more than 30 days, if they have chronic weakness, fever, diarrhea, where they're just losing nutrition, they're losing fluids. There's this dementia complex that I kind of talked about before, where they can have this memory impairment, personality changes. Really important that we focus on safety if that's what they've developed. Infection, that's going to be your biggest thing with your HIV patients, that we want to try to combat infection. Cancer, Kapowski sarcoma, right? So it's a bone cancer. That's more likely you'll see that if somebody has HIV and they haven't had treatment. If they've had treatment, they're less likely to develop that. But if they haven't, that's usually when we're seeing Kapowski sarcoma. They're diagnosed usually by doing blood draw and seeing if they have the HIV antigen in your body. I'm not going to get into all that. I don't think you need to know it. So normal, like I said, normal CD4 count is 332. What's the number that we usually look at diagnosing with HIV? 200, right? 200 or less. We monitor those, and then we're also going to monitor them during antiretroviral therapy as well. Like, so remember, you can be diagnosed, like that graph showed, you can be diagnosed with HIV and your CD4 count is still going to be pretty high. We want to keep maintaining it at a higher level. So if we can use those ART drugs to suppress that HIV from replicating, bonding, all of those things, we're going to be able to keep our immune system functioning better. They might do some viral load testing. I don't really care about that. They're also going to do some other tests, right? Because depending on how you contracted HIV, you might have contracted some other things, right? So syphilis, all the types of hepatitis, liver chemistry panels, they're going to look through all those things, make sure there's not something else going on as well. Want to make sure that we know that the patients know there's no cure, but if we start this antiretroviral therapy, we can suppress the virus and really keep their immune system functioning the best that it can. Also want to make sure with these people, we're looking at safety, at healthcare promotion. Oh, that sounds familiar from all the things we've been working on, right? So what are the vaccines that they need, right? Can we vaccinate against hepatitis? Do they need their pneumonia vaccine, their flu vaccine? All of those things that can be so important. The antiretroviral therapy. So 3 drugs in at least 2 classes of those treatment categories. So like I was saying, like the different stages or the cycle of HIV, you know, you have at least 3 of the medications. hitting it at least 2 of those different stages to try to really stop the progression. Bum, bum, bum. I'm not gonna go through the drugs. Okay. Let's get back into groups. Oh, we're almost done. Let's take a break. Yeah. All right, let's break at, let's take till 10:25. And then we're gonna come back and do a couple activities. You're probably gonna be out of here early. So, yay.
Because the sun.
Only because of the sun.